Think about how quickly life can change. 1 minute you're mobile, the next a fall leads to something like a hip fracture. For anyone looking to get a solid, efficient understanding of crucial medical topics, this one really, well, it packs a punch in terms of impact.
Absolutely. It's a
Well,
major event. And that's precisely what we're zeroing in on today.
Yeah.
Hip fractures.
exactly. So we've got our hands on some really comprehensive revision notes. They cover, everything from the basic definition right through to management strategies and potential complications.
The whole 9 yards.
Pretty much. Consider this your streamlined, high-yield exploration of the ins and outs of hip fractures. Our goal, it's to give you a crystal clear overview. Perfect if you're revising for exams or maybe just aiming to get a firm grasp of the essentials.
Okay, so let's maybe lay the groundwork first.
Yeah.
What exactly is a hip fracture? When we say that, what do we mean?
Okay, yeah, let's unpack this. A hip fracture is basically it's a break in the upper part of your thigh bone, the femur, right up near where it connects with the hip joint.
Right, the proximal femur.
Exactly. And it's not just one single thing. We mainly see three types. You've got fractures of the femoral neck, that's right up near the ball, the head of the femur. Then there are intertrochanteric fractures. They happen a bit lower down between those bony bumps, the trochanters. And finally, subtrochanteric fractures, which are even further down the shaft of the femur.
Understanding the causes is, well, it's key, isn't it? Trauma, like a fall or an accident, is common, obviously.
Yeah, the usual suspect.
But we also really need to remember the role of underlying conditions. Osteoporosis, for instance. It weakens the bones so much, makes them far more likely to break.
Precisely. You see these fractures a lot in older women who have osteoporosis. Now, here's something really critical to remember. If that fracture is displaced, meaning the bone ends move significantly apart, it can actually damage or even cut off the blood supply to the femoral head.
The blood supply issue.
Yeah. And that can lead to a really serious complication called avascular necrosis. Basically, the bone tissue dies because it's not getting enough blood, kind of like a plant wilting without water,
That's a good analogy.
Yeah.
And that risk, it leads us directly into why we classify these fractures, right?
Yeah.
Just saying it's a hip fracture isn't really specific enough to guide treatment or predict how someone might do.
Exactly right. Classification helps us be much more precise. So first, we look at where the break is relative to the hip joint capsule, that sort of fibrous sac around the joint.
Okay.
So you have intracapsular fractures, sometimes called subcapital. These happen inside the capsule from the edge of the femoral head down to where the capsule attaches.
Inside the capsule.
Then you have extracapular fractures. They happen outside the capsule. And these are further split into trochanteric and subtrochanteric, with the lesser trochanter, that smaller bony bump, kind of acting as the landmark, the dividing line.
And for those intracapsular ones, inside the capsule, the Garden classification is a really helpful tool, isn't it? Helps gauge how stable and severe the fracture is.
Right, the Garden classification. Let's sort of picture this as stages of increasing severity. Type I is stable. Imagine the broken ends are kind of jammed together, impacted, and angled slightly outwards in valgus.
Okay, impacted.
Type 2 is a complete break, but crucially, the pieces haven't shifted out of their normal alignment. It's still lined up.
Undisplaced.
Exactly. Then type 3 is where things start to shift. There's displacement, the fragments might be rotated or angled, but there's still some contact between the broken surfaces.
Right.
Partial displacement.
And finally, type 4 is, well, complete disruption. The bone ends are totally separated. No contact at all.
And like we touched on, that risk of disrupting the blood supply, the avascular necrosis risk, it's highest in those more severe types. Garden the 3rd and 4. Makes sense. Definitely. Okay, so we've got the what's and the how we classify it. Now let's talk about the why, the etiology, the causes. And the big one, especially as people get older, is falls.
Absolutely. Falls are a major cause, particularly in the elderly population. But we really can't talk about causes without stressing the role of osteoporosis again.
No, it's central.
It really is. It's this silent condition that just weakens the bones, makes them incredibly fragile. So even a relatively minor fall, something that wouldn't harm a younger person, can cause a fracture.
And while falls in older adults are a primary driver, we should remember that high-energy trauma, think car accidents, major sports injuries, that can cause hip fractures in younger, healthier people too.
True. Different mechanism, same outcome sometimes.
But what's quite sobering, actually, is that in older people with severe osteoporosis or maybe even metastatic bone disease where cancer has spread and weakened the bone, sometimes even a simple twist or a very minor bump can be enough to cause a fracture.
That fragility really highlights why understanding the risk factors is so crucial. So who is most likely to get a hip fracture?
Well, unfortunately, just getting older is a big risk factor.
Right.
Increasing age, our bone density tends to decrease naturally over time.
Hmm.
Then, as we've said, osteoporosis is significant. And osteomalacia, too, another bone weakening condition.
Right.
We mentioned falls, but maybe think why people fall more as they get older. Things like poor balance, maybe reduced core strength, problems with walking gait disturbance, we call it sensory issues too, like poorer eyesight, all contribute.
And there are other factors as well. Being female puts you at higher risk, statistically,
Yeah.
largely due to hormonal changes, especially after menopause, affecting bone density.
Yep.
Having had a fracture before any fracture really is another risk marker. A sedentary lifestyle doesn't help either.
No, weight-bearing exercise is key for bone health.
Exactly. And certain medications, long-term corticosteroids are a classic example, can weaken bones. Lifestyle factors too, smoking, heavy alcohol use, they also increase the risk. It's often, a combination of things.
Yeah, rarely just one single cause. So we've covered the who and why. Let's get into the how, the pathophysiology. What's actually happening at the bone level during a fracture?
Well, fundamentally, it's about force meeting resistance or lack thereof. When someone falls or has trauma, a certain force is applied across the hip. If the bone's strong and healthy, it usually withstands it.
Right.
But if the bone is weakened by age, osteoporosis, whatever, it just can't take the stress and it fractures. The force exceeds the bone's strength. Simple physics, really.
And like we mentioned with the classification, where exactly the break occurs and the pattern of the break, its configuration, those things are really critical.
They absolutely are, because they directly impact how likely it is that those crucial blood vessels supplying the femoral head get damaged. And that, in turn, affects the prognosis and the risk of complications like AVN.
Okay. Now imagine someone comes in with hip or groin pain. How do we figure out if it is a hip fracture and not something else? This is where differential diagnosis comes in.
That's a really important question in practice, because hip and groin pain can signal a whole range of issues, can't it?
Definitely. You could be looking at, say, a simple muscle strain or bursitis, that's inflammation of those little fluid sacs around the joint.
Trochanteric bursitis is common.
Yeah. Or maybe femoroacetabular impingement, FAI, where the bones in the hip joint don't quite move smoothly together. Or even other kinds of fractures around the hip region that aren't technically the neck of femur fracture we're focusing on.
Pelvic fractures, for example.
Exactly. And that's precisely why imaging is just so vital. A good clinical exam is your starting point, of course, but you almost always need x-rays. And sometimes, more advanced scans like CT or MRI to be absolutely sure, confirm the fracture, and rule out those other possibilities.
Can't rely on symptoms alone. Okay, so we know what it is, the risks, causes, how to differentiate it. What about the scale of the problem? How common are hip fractures, say, here in the UK, epidemiology-wise?
Yeah, in the UK, hip fractures are a really significant public health issue, especially for older adults. The incidence rates, the number of new cases, they climb really sharply with age.
It tends to affect more women than men, right?
It does, yeah. Which, as we discussed, is probably linked to higher rates of osteoporosis in women after menopause. The overall prevalence, how many people have it at any one time, that's influenced by things like the population's age structure, obviously, but also access to healthcare and how effective our prevention strategies are for osteoporosis and fall.
Right. Prevention is key, but when it does happen, what does it typically look like? What are the classic signs and symptoms? The clinical presentation.
Well, sadly, it's often quite dramatic and clear. Severe pain, usually in the hip or the groin area, is number one.
Incapacitating pain.
Totally. The person typically cannot put any weight on that leg. They can't walk. And then there's the visual clue. You might see the injured leg look shorter than the other one, and it's often turned outwards, that external rotation we mentioned.
Shortened and externally rotated. Classic sign.
Classic. You might also see swelling, maybe some bruising around the hip, and their ability to move the hip joint will be severely limited by the pain. In really severe cases, maybe with significant blood loss, they might even show signs of shock, pale, clammy skin, fast pulse, low blood pressure.
And there are a few other things to look out for, aren't there? Sometimes the pain isn't right in the hip. It might be more on the outer thigh or even radiate down towards the knee.
Yeah, sometimes it can even present mainly as knee pain, which can be misleading.
It can.
Yeah.
And it's really crucial to remember, especially with older patients who might be confused or have dementia, they might not actually recall falling or having any specific injury.
That is such an important point. You can't always rely on getting a clear history of trauma. The pain, though, it'll usually be much worse when you try to gently flex or rotate their leg.
Right. Passive movement is painful.
Exactly. And that characteristic position, the leg being shortened, abducted, so moved away from the body's midline, and externally rotated. That's a really strong pointer. Also, sometimes, though less common, there might be a history of aching in the groin or thigh before the acute event, which could suggest maybe a stress fracture was developing or some other underlying bone problem.
Okay. So, based on those clinical signs,
Yeah.
what's the next step? How do we confirm it? What investigations do we order?
Right, confirmation. Well, the absolute mainstay is X-rays. Standard procedure is to get an AP view that's front to back of the whole pelvis and then a lateral or side view specifically of the affected hip.
Pelvis and a lateral hip view. Got it.
These images usually show the fracture clearly, tell us the type, exactly where it is, and also let us check the alignment of the pelvis, look for other injuries. There's also something called Shenton's line we look for on the AP view. It's a sort of imaginary smooth curve along the bottom of the femoral neck and the top of the obturator foramen in the pelvis. If that line is broken or disrupted...
Suggests a fracture, even if it's subtle.
Exactly. It's a helpful little sign.
And what if the x-rays are, I don't know, maybe unclear? Or you strongly suspect a fracture, but the x-ray looks normal?
Good question. That happens, especially with undisplaced fractures. In those situations, we often need more advanced imaging. MRI is generally considered the best next step if X-rays are inconclusive, but suspicion is high.
MRI is very sensitive for occult fractures.
Very. If an MRI isn't available quickly or maybe contraindicated for the patient, then a CT scan is usually a good alternative.
Okay, so imaging is key. What about other tests, general workup?
Yeah, alongside the imaging, we'll do some standard baseline tests. Routine bloods, so a full blood count, FBC, check their kidney function, UNEs, blood glucose, and ECG to check the heart, especially before potential surgery.
Pre-op assessment, essentially.
Exactly. And maybe a chest x-ray depending on their respiratory status or other conditions. Critically, we need to make sure they get adequate pain relief, good analgesia. Though generally we try to avoid NSAIDs, non-steroidal anti-inflammatories in this older, often frail population because of risks like kidney injury or gastrointestinal bleeding.
Opioids or nerve blocks are often used.
Precisely. And it's also really important to assess for any cognitive impairment like delirium and look for and treat any other underlying medical issues, anemia, electrolyte problems, infections like a UTI or chest infection, because these can impact their fitness for surgery and recovery.
Makes sense. Holistic approach. So once we have the diagnosis confirmed, patient stabilized, pain managed, what's the plan? How do we actually treat these fractures? Management.
Okay, management. For the vast majority of hip fractures, the primary treatment is surgery.
Surgery is usually the way to go.
Almost always, yeah. The main options boil down to either internal fixation, using things like screws, plates, or rods, sometimes called nails, to hold the broken bone pieces together while they heal, or hip replacement surgery, arthroplasty.
Fixation versus replacement.
Exactly. And the choice between those and the specific type of fixation or replacement depends on quite a few things. The fracture type and location are key, obviously, but also the patient's age, their pre-fracture mobility and function, and their overall medical health, their fitness for different types of surgery.
And the main goals of the surgery itself are pretty clear, aren't they?
Absolutely. Two main goals. First, get the broken bone fragments back into the right alignment as close to normal as possible. And second, fix them there securely, make them stable so the bone can heal properly and the patient can start moving again.
Anatomic reduction and stable fixation.
You got it. And then after the surgery, care doesn't stop there. Good pain management is vital. Getting rehabilitation started early, physiotherapy is crucial, and also thinking long-term, like addressing the underlying osteoporosis to try and prevent another fracture down the line.
Right, secondary prevention. Let's maybe break down the management a bit more.
Yeah.
What about for those intracapsular fractures, the ones inside the joint capsule?
Okay, intracapsulars. General principle. Surgery should happen quickly. Ideally within, say, 24 to 36 hours of admission if the patient is medically stable. Now, if it's an undisplaced fracture, those garden-type sign 2, we talked about the usual approach is internal fixation, often with cannulated screws.
Screws to hold it in place.
Yep. However, if the patient is perhaps less medically fit or maybe has significant pre-existing arthritis in the hip, sometimes a replacement, usually a hemiarthroplasty, replacing just the ball part might be considered even for undisplaced fractures.
Okay. And for the displaced intercapsular fractures, the garden, the 3rd and 4.
Right, the displaced ones. Here, the risk to the blood supply is much higher. So, NICE guidelines in the UK generally recommend replacement arthroplasty for pretty much all patients who are medically fit enough for the surgery. This could be either a total hip replacement, THR, replacing both the ball and the socket, or a hemiarthroplasty.
Replacement is generally favored over trying to fix it because of that AVN risk.
Exactly. The outcomes tend to be better, especially in older patients.
And NICE gives some pointers on choosing between a total hip and a hemi, right?
Yes, they do. A total hip replacement, THR, is generally preferred over a hemiarthroplasty if the patient meets certain criteria. Basically, if they were walking independently outdoors before the fracture, maybe using just one stick at most, if they're not significantly cognitively impaired, and if they're medically fit for the slightly longer, more complex THR operation and anesthesia.
So better prefracture function, cognitively intact, medically fit, lean towards THR. Otherwise, hemi might be better.
That's a good summary, yeah.
Okay, what about the extracapsular fractures?
Sure.
The ones outside the capsule, intertrochanteric and subtrochanteric. How's the management different there?
For extracapsular fractures, again, surgery is nearly always the best approach unless there are really strong reasons not to operate severe medical comorbidities, making surgery too risky, for example.
Okay.
Internal fixation is the mainstay here, often using devices like an intramedullary nail that's a rod that goes down the center of the femur, or sometimes a plate and screw system like a dynamic hip screw, DHS. Hip replacement is much less common for these types compared to displaced intracapsulars, but might be considered in some very complex or unstable patterns, or if there's severe pre-existing arthritis.
Fixation is more common than replacement here.
Definitely. And importantly, studies show that operating on these fractures leads to better outcomes, shorter hospital stays, better rehab potential compared to trying to manage them non-operatively, like with traction, which used to be done more in the past.
Right. Early mobilization is key. Any specifics for subtrochanteric versus trochanteric?
Yes, there are some preferences. For subtrochanteric fractures, the ones further down intramedullary nails are generally preferred. They offer better biomechanical stability for fractures in that location and might reduce operating time and the risk of the fixation failing later on.
Nails for subtrochanteric.
Generally, yes. For the trochanteric fractures, the ones higher up, around the lesser trochanter, the evidence often supports using an extramedullary implant, like the sliding hip screw, DHS, over an intramedullary nail, although nails are still widely used too. The DHS is kind of the classic, well-established fixation for these.
Sliding hip screw for trochanteric.
Uh-huh.
Okay, so after all this, the fracture, the surgery, the initial recovery, what can patients and their families realistically expect? What's the typical prognosis?
Yeah, the prognosis, it's really variable. It depends heavily on several factors we've already touched on. The type of fracture makes a difference. The patient's age is huge, as is their health and mobility before the fracture happened.
Pre-existing conditions matter a lot.
They really do. How quickly they get to surgery is also important. Delays aren't good. And then, of course, whether any complications develop during or after treatment. But the general theme is prompt surgery, followed by dedicated early rehabilitation. That definitely improves the odds of a better outcome.
But recovery can be long and challenging for many, especially older patients.
Absolutely. Regaining independence isn't guaranteed, unfortunately.
And you mentioned complications. It's important we touch on those. What are the main risks patients face after a hip fracture and surgery?
Yeah, unfortunately, there's a fair list of potential complications. Surgical site infection is one risk, like with any operation. The fracture might heal slowly or sometimes not heal at all. We call that delayed union or non-union. We've talked a lot about avascular necrosis of the femoral head, particularly after displaced intracapsular fractures, even if they're fixed. Blood clots, deep vein thrombosis, DVT in the legs, or pulmonary embolism, PE, if a clot travels to the lungs, are a significant risk due to immobility.
Need good DVT prophylaxis.
Definitely. Pressure ulcers or bed sores can develop from being laid up, and sadly, a general decline in physical function and mobility is very common. Many patients don't return to their previous level of independence.
It's a life-changing event for many.
It really can be. Other potential issues include significant bleeding, hemorrhage, chest infections like pneumonia, and even major medical events like a heart attack, myocardial infarction, or a stroke, often related to the stress of the injury and surgery on an older person with existing health problems.
And mortality rates are quite high, aren't they? Especially in the first year.
Yes, sadly, the mortality rate after hip fracture, particularly in the elderly with multiple comorbidities, is significant. It really highlights how serious this injury is. That's why things like preventive measures trying to stop falls, treating osteoporosis, and then really good proactive care after a fracture, including early mobilization, are so vital to try and minimize these complications.
Absolutely. So just to wrap things up, we've covered a huge amount today on hip fractures.
We certainly have. We've looked at, the basic definition, how they're classified, intracapsular, extracapsular, the garden types. We've explored the causes, like falls and osteoporosis, and the key risk factors.
Talked about the pathophysiology, how the bone breaks, the blood supply issues.
Right, and how to tell it apart from other things causing hip pain, the differentials. We touched on how common it is, particularly in the UK elderly population.
Describe the typical clinical picture, the pain, the shortened rotated leg.
Exactly. Then the investigations, X-rays, MRI, CT, and then a deep dive into management. Surgery being key, fixation versus replacement, the specifics for different fracture types based on guidelines like NICE.
Discuss the prognosis, which is variable, and importantly, the potential complications: infection, non-union, AVN, DVT, functional decline, and sadly, mortality risk.
It's a really core topic in medicine and surgery, isn't it? Having a good handle on all these aspects is just crucial, whether you're directly involved in patient care or just want to be well informed about major health issues.
It definitely underscores that complex interplay between aging, bone health, falls, and the significant impact these fractures have. It really makes you think about, well, how can we get even better at preventing falls? How can we detect and treat osteoporosis earlier? And how can we continue to optimize that whole pathway of care after a fracture occurs to give people the best possible chance of recovery?
Absolutely. Lots to think about. And hey, for those of you listening who are maybe revising this topic or want to test your understanding further, definitely check out pastthemsra.com and freemsra.com. They're fantastic resources for digging deeper and doing some practice questions.